obviously, remember last time we did the full blood count and we talked about how the kidneys are responsible for that. There's lots of different things that the kidneys are responsible for. This is what it is. So it regulates the blood pressure. It helps control the production. You can all read this. So it helps control the production of the red blood cells. Remember last time we talked about the erythropoietin and how the kidneys produce the erythropoietin. So that's what it does. It was something all of us know is that the kidneys are necessary to filter out waste. So that's one of the main functions that we always think about. And that's why, remember, we think about dialysis when the kidney can't get rid of its waste. And that's why you're doing the job for the kidney. So remember, it filters out the waste, which is why it's really important. It regulates, various types of the salt levels in your body, the potassium, the sodium, all of that's done by the kidney. It removes drugs from your body. So remember, sometimes we take medications and the medications the liver and the kidney are very closely involved in trying to metabolize these drugs and excrete these drugs and get rid of them. It balances the body. So I can't read very well. This level of fluid, so the level of fluids within the body, again, it manages it because of the waste, because of the way you're going to understand now as soon as we go to the next slide, how it balances the fluids in the body. And it produces lots of different hormones and things like that. So this is self-explanatory. So if you think about the anatomy of the urinary system, so first let's start big and then let's go smaller and smaller. So when we start big, we think of what is the urinary system made of? It's made of the kidneys, the ureters, which are the tubes that so the kidneys are producing the urine tubes are taking it down to the bladder, and then there's a urethra, which allows the urine to pass out into the, allows the urine to pass out into the open, right? Now, so obviously, again, have a second to look at the slide and look at the anatomy of the kidneys. This is important later, particularly because it will help us understand why in certain cases the kidney tests go off because there's a blockage or there's something wrong depending on which level there's something wrong, that's when it might go off. Okay, so you've had a look at this. That's the anatomy of the basic anatomy of the urinary system. Okay, now let's go into the kidney particularly. So within the kidney, remember when we went on to this, we said there was red and blue. So red, usually in medical diagrams, red always depicts an artery and blue always depicts a vein. So that's classic when we draw medical diagrams. So the red is the artery and the blue is the vein. So there's a big artery and there's a vein going away, and there's a big artery coming down from the heart, which is carrying things to the kidneys. Okay, so you can see that they divide off and then they go to each kidney. Right. So now we're taking one kidney in particular, and you're seeing what happens is the blood that comes in is the arteries, the blood in the artery is the unfiltered blood. So it comes in, it's taken around the kidney. So there's something called nephrons. So if you can look at that, look at the microscopy of the kidney. So it's this kidney-shaped structure. That's why we think of kidney beans and all of that. The artery comes in with the blood that's not filtered. And then it goes to a filtering system, and then it goes out through the vein. The stuff that's still staying in the body goes out through the vein. This filtering system decides what stays in the body and what's excreted out. So you can see that the urine goes out. So this makes it a little easier to understand. If you just have a read of this in 2 seconds, it'll tell you a little bit about how, you can obviously read this later, but it tells you about, in simple words, what the kidney does, right? It's interesting that they have each kidney has 1 million nephrons. So that's like tons and tons. And they're like tiny filtering centers. Okay. So the unfiltered blood comes into the artery from the heart, and then it gets filtered in the kidney. All the toxic waste product is excreted out in the urine. And you can see that the urine, that yellow tube that's coming out of the kidney is you remember the ureter? Let's go back to that diagram. That yellow urine tube, it will come out and it will go down into the bladder and out, right? So yeah, so that's what's happening. And then the stuff that the kidney is going to keep in the body will go back to the vein and will circulate around the body. So that's how it's clearing things up. Okay. So now remember we said we'll talk, there's urea and electrolytes, right? So the U part of the urea and electrolytes is this, what we're going to talk about today. Okay. So the urea cycle, this is again just a little bit of detail for anybody who wants it, but it's not, it's just important because we're going to use these words later. So remember, the urea cycle converts the ammonia to the ammonia, which is a toxic product, is converted into urea in the liver, and then it's transported to the kidneys where it's excreted. So that's why it's important. So urea is a waste product, right? Now the creatinine is something that we've probably heard about, not only from medicine, but in our everyday lives as well, when we look on the TV or in advertisements or on the tube. So I'll tell you why in a second. You might have heard, it's a familiar word to you. So it's produced in the liver, okay, and it's an energy store for fast twitch muscles. It's phosphorylated. So this is just means it's all about energy combining. Remember, the body has lots of process where it combines things together to produce energy. It breaks things down to produce waste product, just like a machine does. It's constantly producing something. So what it does is it provides the energy for the muscle. So, and when it breaks down, it's then excreted. The creatinine, when it becomes creatinine phosphate, it becomes an energy product. And when it's creatinine, it's broken down and excreted. Now, think about bodybuilding, and you remember those people who, take protein supplements and creatinine supplements when they go to the gym. And this is the reason they do it, because they're using this energy cycle of the body where the creatinine and the ATP and the phosphate, they're using that to supplement. So that's why they take creatinine, to make sure that they have more energy for this bodybuilding and muscle building and things that they do. So it's important. Now, again, this is very useful for you to remember that creatinine is linked to muscle, because later we might start talking about cases where you're going to, I haven't used a case particularly, but you will see in your everyday life, when people have low creatinine, usually it might be somebody who's older, who's a slim woman, because they don't have, it's related to muscle mass. So creatinine is linked. The normal creatinine of a person might also, even though it's low, it might be normal for them because they're naturally slim, or they might be ethnically, different ethnicities have different levels of creatinine and things like that. So that's important. Okay, so creatinine and muscle. Okay, now we're going to skip straight into the cases now, because there's quite a few things, and I just want us to do it again like how we did last time, which was super, the interaction. Try to be as interactive as possible, because I'm really trying to focus this on cases that are very CIS cases and things that you might see all the time. I've thought of everything I remember from working in the CIS, and I've tried to put some of that into this this presentation. So try to interact with me a little bit if you can. So acute kidney injury. So it's self-explanatory, right? What it means is acute means it's coming on suddenly, or it's a new thing, and it's a kidney injury. So the kidneys are injured suddenly, and it's a new thing, right? So how do you define acute kidney injury? So remember the creatinine, the urea and creatinine are measured. U's and E's is the U part of it is a measurement of the urea and the creatinine. So those are levels that are there in the blood. So if there's the baseline creatinine, if there's a rise in more than 50%, then that would be an acute kidney injury. Okay. So we're going to know soon what could be causing things like kidney injury. So anyway, so one of the criteria to diagnose acute kidney injury is a rise of more than 50% from the baseline. The second one is if you have a urine output less than 0.5 mils per kg per hour over 6 hours. So how do you diagnose that? Can anybody tell me how you would know this exact level? Of the urine output? I don't know if I've muted all of you. I hope I haven't. Sorry. Any ideas how you would measure? How do they know that the urine output is less than 0.5 mils per kg per hour? That's like so specific. Okay, I'm just going to tell you. So in hospital, for instance, they would catheterize a patient. And you know, they constantly keep measuring. There's calibrations in the catheter. Or even at home, the patient might be already catheterized, and a community nurse like one of you might be going out and checking and seeing how much urine the patient has passed since the morning when you saw them and the evening when you're going on a second visit. So that's the definition of an AKI. Okay, Karen, it isn't muted, right? Like people are like, I haven't muted everybody or something, have I?
No, people can unmute.
Oh, people can unmute. Okay, cool.
Yeah.
Okay. They're just very quiet.
Oh, I think you're asking us a difficult question here.
Oh, sorry. But there's no shame here. So everybody just give it a try. If you even guess the answer, just give it a try. Yeah? Okay, fine. Just saves me, because when I watched back the last video, I thought, oh dear, I talk so much. I should talk less.
No, it's difficult, isn't it?
It's difficult when you can't see anybody. That's true.
Yeah.
Okay. So the first case, really common CIS case, and I'm not going to answer the answers for you now. You have to make an effort with this case. So a 76-year-old man got shortness of breath, green phlegm, cough. How is that linked to a kidney, right? Whatever. Past history of hypertension. His blood pressure is 85/50, and we all know that's low. His heart rate is 115, so he's tachycardic. His oxygen levels are 92%, and his respiratory rate is 25. So he sounds like he's got a pneumonia, right? These are his blood tests. Okay. So again, I've kept the sodium and the potassium, which is the electrolytes part of the U&Es. I kept them the same in all the cases, because at this point, I don't want you to think about that too much at this point, because it might be too much at the moment. So just focus on the urea and creatinine, just for this presentation. Okay. Does anybody want to have a guess what these blood tests are showing and what's happening with this man at the moment? Two different questions.
He's dehydrated at the moment. Just going off his observations, he's got low blood pressure, but then his heart rate is also high.
Yeah.
Which could indicate that he's dehydrated. And then following up with the bloods, his urea is also high.
Yeah, perfect.
Yeah. So is it, an AKI?
Yeah, absolutely. So it's an AKI because he's 118, his urea is high, creatinine is high. And why is this man having AKI? So what could be the reason that he's having acute kidney injury, that his kidneys are not doing very well?
Dehydration.
What are his investigations showing? His new score.
Oh, new score? Can you click back to the previous slide?
Yeah.
What's his temperature?
Great question. His temperature is 39.
39. Jeez, that's so high.
Yeah, patient is septic.
Just got the query sepsis in the room.
Green phlegm.
Perfect.
Low blood pressure, high tachycardic, and with a low saturation as well. We don't know the baseline saturation.
Absolutely. Perfect. So you're so right. So sepsis, you thought about sepsis, and he's fulfilling a lot of the criteria, remember, of the sepsis pathway, like all the triggers that we're thinking of. He's tachycardic, he's got a high temperature. What else comes in the sepsis pathway, so that sepsis is causing his kidney injury at the moment, his acute kidney injury. So we're assuming it's new, and it's because of the fact that he's probably got sepsis. What's the other thing? If you think back now, kidney injury, and there's something else we ask in the sepsis pathway, and there's something we do, particularly in the sepsis pathway, if any of you can remember it, and that will trigger you to remember why its kidneys and sepsis are so important.
His heart rate?
Right.
His heart rate. But we do one thing. We send them to hospital, and when hospital, you'll know there's a 1 hour window. Remember, in a sepsis pathway, there's a 1 hour window. You do a certain number of things when you start
Well, you give oxygen first. Conscious level?
Yes, linked to kidneys. I want you to think about the kidneys. What do we do in hospital linked to?
Are we doing a urinalysis or?
Yes, perfect, but we also do a catheter, right? Because we want to catheterize them, because we want to see how much urine they're passing to keep monitoring it. And we give them IV fluid stat. Remember, we give them 1 liter within an hour in a sepsis pathway.
Yes.
You might not all know that, but that's what we do in a sepsis pathway when we send them to hospital. Within an hour, you have to act really quickly with sepsis, and they do that. So I might have gone higgledy-piggledy and asked you this question a wrong way about, but I just want you to remember that that's what we do in the hospital. So anyway, now forget the hospital for now. Let's think about this man and think about how you're going to manage him. So he's got sepsis. You're absolutely right. What are you going to do next? Sepsis, he's dry. Okay, super. What are the next steps?
Well, because we have a rapid response and the patient is conscious, we encourage the patient to have oral fluids. In the meantime, we'll call the ambulance. Maybe take a sample of blood again and take a good history of the patient, with the patient, whether she has been drinking, how much urine she has been passing. If we can collect a urine sample, it will be good as well.
Fabulous. All great answers.
So where are we? Are we in a hospital or in the community?
Sorry, I can't hear that.
I think the question is that, are we talking about what we're doing in the community when we see the patients?
Yes.
Are we talking about
in
what
the community? Now for us as CIS, we're going in a CIS. What are we doing now? So somebody said hospital admission and, taking a history. I heard taking history, hospital admission, taking a urine sample, asking him more in the history of how much he's passed urine-wise. What's been happening, how long it's been going on, all great answers.
Yeah,
but
I was saying that she's producing green phlegm, sputum, so maybe it is the source of infection there that has triggered the sepsis.
Maybe give what, sorry? I didn't hear that. What did you say?
The source of infection.
Mm-hmm. Mm-hmm.
With the green sputum. We don't know how long he has been producing that sputum.
Sure.
Well,
so you might start some broad spectrum antibiotics, you feel, while you're waiting for the ambulance?
With a rapid response, it's a bit difficult, so we could ASAP send her to the hospital because she needs fluid management, she needs antibiotics. Kidney is failing as well, like acute kidney injury. So
Perfect.
I think in this case, we'd call an ambulance and it'd be like a category 1. So they would be there in 20 minutes.
Okay, good. So you're going to call an ambulance urgently because she's septic and she needs to have, remember again, I've not put a slide on sepsis bundle pathway, but try and go back and look at the sepsis bundle pathway, which the hospital follows. It's all about time. It's all about the quickness of it. Now, that's true, but the problem with this lady, was she a man? He was a man, actually. The problem with this man is that he's refusing hospital admission.
Oh.
So classic, right? This is our classic CIS.
Yeah.
So now what? Now what are you going to do? So this man, you've already established sepsis and AKI. Now how are you going to manage him at home?
So you have to take blood. Then you encourage the person to drink more water whilst you are there. Then you call the GP to prescribe a broad spectrum antibiotics. And if you can get a urine sample as well and a sputum sample, that would be great.
And we have
such brilliant answers. Excellent.
And you give paracetamol every 4 hours. Well, you tell the patient to take paracetamol every 4 hours.
Mm-hmm.
Paracetamol to control the temperature.
Okay, great. So you're thinking clinically. I know you're obviously all going to do other things as well to make sure he's safe at home and, he's got some help. He's, maybe got carers now in. I'm sure you've all thought about those kind. This is not the remit of this presentation, but I'm sure you've all thought of it as well. Okay, so excellent. So you've thought of antibiotics for that infection that he's fighting. you're thinking, okay, he's now got this deranged U&Es, so he's dry, he's dehydrated, he's getting kidney injury. So the way to solve it is obviously giving him good amount of fluids, so encouraging him to have lots and lots of fluids. Again, remember, like all of you are OTs and PTs as well, and you're thinking with all your hats, because that's what you do in the community. You think the carers will come in, they will encourage him, so you'll give them special instructions, make sure that he's having lots of fluids, that you're trying to hit some targets, right? Okay, that's great. Fine. Now, what next? So you've antibiotics, you've given him this, and you said you've taken blood tests. So day 2 now, how will you keep managing this patient?
I would suggest as well on that first day, is there a capacity assessment done? Because if he has sepsis and if he's delirious, does he actually have capacity to refuse admission?
Super. I was just going to go back to that. It's excellent. Super. So yeah, so Justine's also check that there's a capacity assessment and make sure that this patient has capacity and he isn't just speaking because, so, I mean, it's useful. I don't know if it's useful to you guys, but like I've always been confused about why patients make the decisions that they make. You know, is it because they're so sick that at the moment they can't think straight and they can't, and that's really scary as a practitioner to think, gosh, this man must be so sick and he's acting completely out of ordinary because of his sickness. And Dr. Da, who's our elderly care consultant in Hammersmith and Fulham, I remember calling her once with a patient like this and saying, I just don't know why he's saying no, but he's saying no. And she said, think about his background. What is he like otherwise? And so this was a man who was septic, but he was somebody who had always disengaged from services. This was his history, it was his pattern. So she said, in those cases, you definitely do know that he's acting like his normal self. If it was somebody who was acting completely, I mean, you still have to keep thinking about it. But I'm just saying that if there was somebody who's acting completely unlike their normal self, then you have to, escalate this and use more people to make a decision and try and see how you could do a capacity assessment, like Justine said. So that's brilliant. Okay, so yeah. So you've assessed his capacity, started his medications, encouraging his fluids, got him some home care. And now how are you going to monitor him? So he's still on your books now. He's not going to be off your books until he's well. So what next?
I would suggest that he needs BD visit initially.
I can't hear you, sorry.
Because of the temperature, which is 39. And I would suggest visit 2 times. And he's refusing hospital admission. And my other query, there is one query that, do you think that we need to send a blood culture for him?
Mm-hmm. Good query. Yeah, fabulous. Okay, and I'm gonna wait for some more. I really like those answers are really great. And let's. So one thing you said was you'd visit him 2 times, right? Because he's so sick and his temperature is 39. You want to keep a little bit closer eye on him. So that's a great clinical decision. Yeah.
Because he might not be drinking, so we have to educate the carers as well to prompt oral fluids. Yeah. The fluid management is first at home.
Brilliant.
And also the blood pressure is low, so we can monitor also with the blood pressure and the heart rate might be down and temperature also will go down.
Excellent.
With the antibiotics, it will take anyway 5 to 7 days.
Brilliant. So you're keeping a close eye on him, making sure he's getting his antibiotics, monitoring his observations, checking there's improvement rather than getting worse, or at least absolutely right, yeah. Making sure he's not changing his mind about hospital admission. Every time you're seeing him, you're talking about, are you sure you don't want to go and rediscuss it again, particularly based on how he's responding. So yeah.
And also, if he's, I don't know whether this patient is mobile. If the patient is not mobile, we have to check the pressure areas, whether there is any pressure sore around, and check whether he has got any wound that is infected.
Great.
And whether the patient is diabetic, so we have to keep a close eye because the blood sugar levels will go up with the infection. So we have to monitor the blood sugar as well.
Great. So you're thinking about the collateral stuff that he's got, the comorbidities, because none of our patients ever just come with sepsis and refusing hospital admission and AKI, do they? They come with so many other things along with that. You're right, diabetes. One more thing that's really important with this guy, with the fact that he's got this, you know, when you're thinking of your history, your past history, so diabetes is one. There's another one that's really important. And lots of other things are important, but one particularly it's important for us.
Maybe patient has been, I don't know, patient's saturation is 92, so we don't know whether patient is COPD or asthma or on steroids, which is maintenance dose. That might affect as well.
What about his blood pressure? His blood pressure is low. Is there something that could be making his blood pressure low?
If he's on antihypertensive, then we have to stop.
Perfect.
And also in this case, diabetes, metformin, we have to stop as well, because this is going to also act on the
So are you on nephrotoxic medication?
Perfect. Wow, that's a great answer. So super answers there. I can't see who's answering them, but that's really great. So metformin, you're right. So diabetes is important because of his sugar levels. So when you're assessing him that first time, and when you're assessing him every single time, you're going to start thinking, you have to think about his sugar levels. You have to think about the fact that if he's on metformin, it's a nephrotoxic agent, and that only means that it's toxic to the kidneys. Nephro is kidney. Remember nephron? Nephro is kidney, so it's toxic to the kidney. So you want to hold certain medications when somebody is having a poorly kidney. Okay, so metformin is a great example that you need to look at. The other one was the antihypertensive, especially with this man. He's got a low blood pressure. So, you know, he's septic with a low blood pressure, and he's, you know, his hypertensive medications, he's going to pop his medication again in the evening, and he's going to get even worse. So you're totally right. So you want to see what hypertensive medications he's on, take away his tablets, make sure that's all done. Hypertensive medications often act on kidneys, most of them, or all of them actually. So that's
a review of the medication.
Correct. So you want to review all the medications he's taking and seeing what could be toxic to the kidney. So you could do that easily with a BNF, right? And just check and see, and make sure, obviously run it past the GP and, you know, the medical team as well. But so that's a great starting point, that you're already thinking ahead, and that's fabulous. Okay, so metformin, you're stopping the nephrotoxics, great. Okay, that's day one. All of this you're doing on day one.
And also if the patient is on anticoagulant, we have to check that one, because it might interact with the sepsis. The INO can go up.
Brilliant. Okay. So you're really thinking, like, you're really spread out. If you think of a spider diagram, you're really spread out well, because you're thinking about all aspects of your holistic care for this patient, which is great.
Because if we are checking the medication, we have to take into consideration all the medications of the patient.
Sorry?
I said if we are doing we are checking the medication the patient is taking, so we have to check everything and then just see how it is interacting with that condition with sepsis.
Okay, super. Now, so you're doing that. You've got a list of things. So I'm going to try and summarize this for you a little bit in a list. Not all of the things you've said, but some of the things that's necessary for AKI in a second. What else? So next day, what are you going to think about now again? How often are you going to visit this patient? You said already twice a day, right? So perfect. Okay.
And
next day, what you can do?
Follow up over the day. We can make a follow-up phone call, just to see how he is. Maybe the carers can give us a feedback on how he's behaving, whether he's confused or he's refusing to drink or increase oral fluids. So that's a concern if he's not taking enough fluids.
Mm-hmm.
So I would suggest that I keep a fluid balance chart there and also monitor the urine output.
Perfect.
Carers to recall.
That's a great answer. So you're going to keep a fluid chart there. Yeah. Ask the carers to monitor the fluid output and the input to see that he's taking enough in, he's passing enough out. Perfect. Great.
Your question is the following day, what are you going to do? So you do a home visit, you check the OBS. If the blood pressure is too low, Then you calculate you try to do a rough estimation, because it's very difficult when you don't have a close monitoring about how roughly the urine output.
Mm-hmm.
Then you assess the capacity as well. So if it's not improving, you assess the capacity.
Mm-hmm.
If the person is improving, then you think about monitoring the patient. So I will probably take another set of blood just to see how the kidneys are doing as well.
Correct. And sometimes it helps when you take a second set of bloods, and if things are getting worse, and so often patients, right, like the second or third day after they're still getting sick, they're getting sicker, they're feeling sicker, the bloods are getting worse, and you say to them, look, it's getting worse, it's not getting better, we're not sorting this out here, you need to go in. Then sometimes people do respond after a little while. I think they seem to have a bit of a, in my experience, I found that sometimes that they do say, okay, fine, we'll do it now.
So might be the sodium might go up as well. We never know with a sudden.
So you're looking at the sodium and the electrolytes, the sodium and the potassium and things as well, yeah? So you're doing the U&Es, you're doing the urine output. How can you, when you assess them, obviously you're going to do the news thing again. What else?
But this time around, we would like to know the full blood count as well, to see the white cells, the level of the white cells and CRP.
Yeah.
It's day 2 of antibiotics. So
again, you're thinking holistically. It's not only the kidneys, it's his white cells, it's his CRP.
We need to make decision based on all these things. Are we like, is it safe for the person to stay home? Or we might have to consider other things. Because if the person is deteriorating, then we have to put DNA in place.
Mm-hmm. Brilliant. Okay, super. Great answers. So yeah, you're doing a really holistic assessment. Now I'm just going to give you the 7 steps. So you've done really great, and you covered most of this now. Just gives you a little bit of, just for you now, you can use this as a trigger. If you guys have this on a phone, take a picture of this when you get the presentation. It's a really great way to just, even I don't think sometimes you forget to do all these steps. So it's great for you to think about it and try to remember to do all these things. So you're confirming the AKI, you're assessing the fluid status, and we're going to come to that in a minute of how you assess fluid status, right? So you assess fluid status because remember, he's clearly dry. But sometimes in some cases, people might have kidney injury and be wet, which means that they have peripheral edema and things like that. We're going to come to a case like that later. So it's important for you to know what his fluid balance is, what his fluid status is. You talk about the full neurological, physiological assessments, which you guys do anyway, and your new score is there. So sometimes it's really heartening to see a new score improving with a patient like this, right? So that's great. You're doing a urine dip. I think you mentioned this earlier, and this is important. It's going to come up in the next case why it's important, but yeah, it is important. The urine dip is important. Give me one reason for this case why it's important. With this case with sepsis, why could the urine dip be important?
It might indicate whether they've got a UTI. Yeah,
exactly. So you're confirming that he doesn't have a pneumonia as well as a urine infection, right? So you're checking that he doesn't have a sepsis particularly. You're doing a whole septic screen. Sorry?
Oh, sorry, Karen was on the phone, sorry.
Okay. So yeah, so you're doing a urine dip, and it's important here, and it's also important in the next few cases that are going to come. Okay, and you stop the nephrotoxic drugs, which you've already done. All of you did brilliantly. The diabetes medications, the anticoagulation, you're going to check and see how they're doing. You're going to stop the hypertensives, and the nephrotoxic hypertensives particularly that are very classic are things like ACE inhibitors, ramipril, losartan, that's ARBs. So those are ramipril, losartan, furosemide, for instance. Imagine this poor man is, hypovolemic, and he's going to have furosemide and lose some more fluid through his kidneys. So that's going to be toxic, really toxic for him. So remember those nephrotoxic drugs, you withhold them for a little while and you keep monitoring him. So great. Daily U&Es, which all of you said you're going to do, and you're going to continue doing that until it's back to baseline and there's an improvement. And This is really for hospital. Consider renal ultrasound and urinary catheter. So things aren't getting better. That's when you start thinking about this. Okay. So great. So this is a great little reminder for you guys when you go and assess a patient with sepsis. So how do you assess fluid status? We talked about it briefly just now when I talked, but can you think of what you could do? Think head to toe.
Dry lips, dry tongue, skin turgor.
Yeah, great. So physical features, yeah.
And the intake and the output. How much the patient has taken over for 24 hours?
Sorry?
The intake, how much the patient has taken over 24 hours?
Correct. Okay. So intake and output. Perfect.
Is the patient sweating as well? Because you can use fluid to sweat.
Yeah, that's good.
Have they got any wound that is oozing?
Mm-hmm.
Have they got any wound?
Yeah, got it. Yeah, that's good. Yeah. It's not a classic fluid. You see, that will be a very, very obvious thing. It's not what we classically think of as fluid status. It's important because people can also have AKI, the type that you saw just now, even from a bleed. So suppose they had a massive bleed in their tummy, that would make them low volume of, fluid in their body, and that would also cause a kidney injury. So you're so right that that's important. If they're bleeding, absolutely. Something else, think about what tells you if a patient is wet or dry. We use those words sometimes. We listen to lungs. What are we listening to when we're listening to lungs and things like that?
If they have any fluid in the lungs as well.
Yeah, crackles and fluid in their lungs. We check their feet for pitting edema. So those are the kind of things. So capillary refill we didn't talk about. Postural blood pressure is a great one, and you all do that. And obviously a lot of it tells you as well, like in a case like this, it'll tell you how hypovolemic he is, if he can't sustain his blood pressure when he's standing up. So that's a common one that you guys do. And so it's a good one to remember. JVP you do as well. These are all heart failure related ones, right? Auscultated lungs, peripheral edema, urine output. So you got all of these. Great. Okay. So the one that you just heard, so that is acute kidney injury, and the commonest cause that we have for acute kidney injury, before we go into this, is sepsis, the commonest cause. So the commonest types, there are 3 types of acute kidney injury. It all links to which part of the kidney is involved. So is it before the kidney, which is what happened here? It was sepsis that came before the kidney. Is it a problem with the kidney itself? Or is it a problem after the kidney? So it's called pre-renal, renal, and post-renal. So this case that you saw just now was a pre-renal cause. And that makes sense, right? It's sepsis. It's something not directly linked to the kidney as such, but because of the way the body is at that point, it's affecting the kidney. So pre-renal cause. Another pre-renal cause I mentioned to you when we were talking earlier was like you said, blood loss. If you got a wound somewhere, you got an ulcer, bleeding ulcer, you're losing blood in your gut, that can again cause kidney injury, and it'll be pre-renal cause. Okay, so that's a great one. So you've done that. Okay. Now again, for this case, I want you to remember what the definition of acute kidney injury is. Okay, so remember it was more than 50% of the creatinine from the baseline, or urine output less than 0.5 mil per kg per hour in 6 hours. Okay, so you've done that. Okay, so this is case 2. Have a little read of it. And then I'll say it loudly to you as well. Okay. So this is an 85-year-old female. She's had diarrhea and vomiting. She has a past history of hypertension. Blood pressure 102/80, not too bad, but we don't know what she's normally like. She's hypertensive, so she's probably on some medications. Heart rate 94, SATs 98, respiratory is normal, and these are her bloods. Anybody with any answers? Is this acute kidney injury? it's tough to be put on the spot, but it's not technically acute kidney injury, right? The baseline is 80. Remember in our full blood count readings, in our full blood count things.
50%.
Sorry?
The creatinine is more than 50% rise, then her baseline. So it's not like, it's not more than, but it's up 50%. Like her baseline is 18 and now her creatinine is 120.
Correct.
50%.
Correct.
Yes.
What about, like, look, the urea is raised as well. Does that make a difference to deciding acute kidney injury?
I think it's borderline, because with this one, we know what is going on, which is EMB. If you are having diarrhea and vomiting, obviously, you're going to lose fluid. On drink.
Well, we don't know how many times, what is the frequency of the DNV. And if patient is unable to tolerate oral fluids, then he might go into AKI, which is more acute. I mean, severe.
Okay, so this isn't classically acute kidney injury, right? But the important thing here is that because it's not more than 50% above the baseline. But the reason it's important is because we have to start thinking that this patient is going to get worse. He's got diarrhea and vomiting. They're losing fluids. So we can't ignore this and say, oh, it's not AKI, that's fine. So we have to think about this. And this is an important one for us to start paying attention to. How do you manage this patient? I mean, like, you obviously done the whole thing with sepsis and it's similar, but essentially what would you do with this patient? How would you manage him? Oh.
So how often is the person vomiting and having diarrhea?
Great. So you're going to ask her the history again and start asking questions about how often it is, how bad it is. Great. Yeah.
Because patient is in the house, it's not in the hospital. So we have to manage it with fluids. And give us some anti-emetic and also.
But we need, I think we need to define, is she able to tolerate anything oral? That's the first thing we need to ask.
Great. Yeah, she is able to. So her vomiting, she's had 2 episodes this morning, and they're much better than what she had the day before, which was, she had 6 episodes a day before. So it's getting a little bit better. And she's got diarrhea. And like you asked, the diarrhea is important. And the questions, remember, it's never just diarrhea. You have to be curious as you can be. And I always say this. Yeah.
So yeah, how overflow from constipation.
Correct. Okay. So overflow, that could be overflow. And things like how often, what's the color, is there blood, stuff like that. And then is there tummy pain associated with it? Is it actually diarrhea from like a pseudo obstruction or something like that, like a partial obstruction that's causing her to have like some kind of diarrhea symptoms, like Justine said, like a constipation, overflow. So yeah, you're totally right. So you've got to think of all that, and then again, she's feeling well. She's feeling much better.
If we check the medication that the patient is taking, whether the patient has been on laxatives, whether there is any history of long-standing constipation that hasn't been treated, and then all of a sudden she starts taking laxatives, we don't know, so related to overflow. And any antibiotics might be causing that. We don't know whether the patient is on new antibiotics.
Correct. Okay.
So we have to check.
Yeah. So what could be the cause? Yeah, absolutely. So again, the same things that you thought about last time, it's the same stuff again. The reason this is important is I want you to think that with all your patients, you want to think about what medications they're taking and what impact is it having on their blood. So it's such a, I promise you as GPs, sometimes we forget about it, and the CIS reminds us to do this, and it's fabulous. And that's really important that all of you keep thinking, if this patient is having some sort of kidney injury and the kidneys are getting affected, either because of So this is again a pre-renal cause, right? It's diarrhea and vomiting, pre-renal cause. Again, there's loss of volume in the blood. There's loss of fluid volume. And so the kidneys aren't getting perfused enough, which is why they're getting tired and dehydrated and sick. So again, the fact that you all are all thinking about the drugs that they're taking, what can you make practical changes to these patients? And that's what the CIS is great at. So I think, you remind all of us GPs to do these things sometimes. So great. So you thought about the hypertensives, you've thought about the medications this patient's taking, you're giving them lots of fluids, they're getting better, but you're going to keep an eye on these kidney function tests, obviously. And you're going to keep an eye on the patient's symptoms as well. Make sure that they're not changing, whatever. Okay, so super. And you're going to give them diarrhea, which I think we don't say enough. One little tip here, I'm just going to say this now. There's some messages here. I'm not reading them. Is that okay?
Mainly from me and Justine. I just said if the patient is on laxatives, blood pressure medication, or diuretics, we would need to stop those medications because, of course, that would make her diarrhea worse if on laxatives, or blood pressure medication or diuretics would make her blood pressure worse, and the perfusion in her system, which is bad already, make it even worse. So these are the medications that would definitely need to be stopped, plus metformin. Usually if the patient is on metformin, that's something we would need to stop in someone who is unwell with diarrhea and vomiting.
Correct. I completely forgot the laxative bit. And so that's fabulous. So that's a great thing. Again, how sometimes, you all work together and it works so much better when there's two heads thinking, 10 heads thinking about this. So that's great. So laxatives, diuretics, antihypertensives, perfect. And one thing, just a little thing, just on the side, because it always comes up in general practice and sometimes it happens in the CIS as well. Patients buy loperamide and most diarrheas are viral or bacterial. They're infective diarrheas, right? So especially when there's a classic history like a food poisoning or contact in a hospital or contact with somebody, what you shouldn't try not to encourage them to take loperamide. So that's really bad for you, because what the loperamide does, remember, it's a thing it's an anti-motility drug, so it stops you having diarrhea. And what it does is it keeps the bacteria, so the body's protective mechanism is to have diarrhea. The body is recognizing there's a bug in the body that it wants to get rid of. When you take loperamide, you stop the body from doing that, which means that it's kind of keeping the toxin and that bug inside the body for longer. So sometimes, in practical sense, clinically, I've seen people who've taken loperamide with diarrhea and vomiting, they have a very prolonged illness as a result of the diarrhea and vomit, as a result of the loperamide. So try to tell them no loperamide, instead lots of diarrhea. So something that actually, not lots, but you've got to look at their fluid status, and diarrhea is important. So when they go they have diarrhea, they take diarrhea instead of loperamide. So that's just a practical tip from me. And somebody mentioned something about antibiotics to see if it's C. diff diarrhea. So that's again a great thing to think about. Super answers. Great. Okay. So that's not AKI, but that's important. So AKI diagnosis, again, you saw what the diagnoses were. They're very specific. Urea is not specific. Urea can be high. So we don't look at urea when we're diagnosing AKI. It can be high in things like trauma, in surgeries. It can be high in infections. So lots of different reasons. And EGFR, you must have seen that we often talk about that when we're looking at blood test results. It's used for chronic kidney disease. It's not used for acute kidney injury. So those two things, there are two parts of these tests that we don't look at when it comes to the AKI. AKI is purely looking at the creatinine and the urine output. Now the electrolyte imbalances, again, I remember I heard somebody say something about sodium levels, potassium levels, and you're totally right, especially with somebody like diarrhea. They might obviously lose salts, so they lose sodium. They might be hyponatremic, low sodium levels, but that doesn't diagnose AKI. It can happen as a result of it, and can happen as a result of what's causing the AKI, but it's not a diagnostic test. Okay, so you're getting a hint of what AKI is. You thought of acute kidney injury. We've talked so far about pre-renal causes. So we've talked about sepsis, which is a really common cause we're seeing in the CIS. Diarrhea and vomiting, another common cause we're seeing in the CIS, and bleeding. So lots of patients of ours who got melena or bleed from the ulcers or whatever they are. So that could be another cause. So great. Okay. Now case 3.
Veda, I'm aware of time.
Is it too late?
Clock now. So we may need to potentially wrap it up and
okay.
add this to part 2.
Okay, no problem.
No, the Westminster team says no. Okay, shall we can add another 10 minutes if people are happy with that on the call as well. We can do thumbs up or just shout out yes or no, because I don't want people to miss it. Okay, let's do the yes, everyone. Okay.
Okay, fine. Please, okay. I can't see. I'm so okay.
Okay, wonderful. So we are recording it anyway. So for people who miss it, we do. For people who miss it, we are recording it, and they can watch the rest, isn't it? So let's do the last case. This is the last case, Veda.
Last case. It's not actually. It's one more case.
Okay.
Let me hurry through this one. It's not terribly important, maybe. So let's go faster through this one.
This is an important one because we see this a lot, don't we?
But it's not so common to cause AKI. So I'm just thinking at least that way it's not so terrible. But let me go through it. And then anything that we haven't covered, I can just push it into the next one. Not a problem.
Exactly. So we do this case and the rest we're going to add to the next one.
Yeah.
Okay, wonderful.
Yeah. Okay, so this case, have a read, and a 78-year-old man, very common for us, lives alone. Actually, we had a case like this recently, didn't we, Karen? So
we did, yes.
Spends most of, I know exactly this common.
Yeah, across the Triborough.
Most of his time in bed. He's on his way to the commode, and then after his carers have gone, they've tucked him into his bed, and at 7 in the evening, he's on his way to bed and he falls, and he's found by the carers the next morning when they come to care for him. So he's been on the floor for 10 hours. He's classic. He's like, no, I'm fine, not a hassle. I just want to stay at home. And then 2 days later now, his carers are getting more and more worried because this man, he doesn't have any pain anywhere, no broken bones or anything like that, but he's not feeling well. He's got a poor appetite. He's not passing urine as well as he should do. Look at his history. So he's got hypertension, heart, MI, and he's got diabetes. His obs are all right. So the question with this man, so this is his blood test. So we already know he's got AKI, guys, okay? So that's fine. His baseline is 80 and his creatinine is 180. So more than 50% rise of creatinine. So he's diagnosed as AKI. So what other tests are we doing? What are we thinking about particularly? I want you to think of a certain thing here.
He's had a long life, so is there a test they do for rhabdomyolysis? Is there
yes.
A blood test? I don't know what they do.
Super, excellent. And that the lysis is also a great word to remember because it's called, there's a word for it. I don't know if anybody knows that condition where you've had a long lie, you can have muscle breakdown, and it can cause something called rhabdomyolysis. So it's classic with, this is why there's one blood test we do, and you might hear us in a meeting saying, have you done this level with a long lie? Does anybody remember what it is called?
CK.
Yeah, perfect. Creatinine kinase. Think again. Remember creatinine, muscle. I feel so happy when I make those connections for myself later. When I read stuff. Like, creatinine, muscle, creatinine kinase. It's like kinase, you've kinetic, you've broken it down. So the CK is high because of the breakdown of these muscles. So this man who has such risk factors, look at him. He's, frail. So he's probably really already has very poor muscle mass. He's spending most of his day in bed already. And then he falls and he's got this traumatic injury on his muscles and his body, and he's lying in one position without changing it for such a long time. Remember, he doesn't have the pressure bed and all the benefits that he would have had if he was in bed. And so his muscles are going to break down. And that's going to release something called myoglobin. And that then that's excreted to the kidneys, and that is what is causing this kidney injury. So And they'll say something called cola colored urine. So typically myoglobin is cola colored urine. So in this case, although it sounds like it is a pre-renal cause because his fall is what happened, the real cause is the problem is with the kidney, because what's happening is this myoglobin is going in, the kidney is not working fast enough. Wait, somebody's sending messages. I don't know, Karen, is there anything important?
It's just me, I'm repeating it. CK myoglobin release.